Well, hello, everyone. It is with great honor to introduce Dr. Richard Brown, our Global PAD Advocate of the Year 2024, as recognized by the Global PAD Impact Awards through the Global PAD Association. Dr. Brown's journey as a champion for peripheral artery disease awareness and treatment has been nothing short of extraordinary. His nomination for this prestigious award came directly from the hearts of patients whose lives he has touched through his multifaceted efforts to combat PAD. During his tenure as a senior medical executive in cardiovascular and metabolism medical affairs at Janssen, Dr. Brown was at the forefront of the battle against PAD, particularly focusing on the disproportionate impact on communities of color. Now, since then, he has continued to be a tireless advocate, expanding his influence and impact. Dr. Brown's powerful voice resonated with millions when he appeared on ABC's Severed, bringing critical attention to the plight of diabetic patients suffering from PAD. And his groundbreaking work with the Save Legs, Change Lives program, it's a PAD testing program. Well, it's been instrumental in early detection and prevention of so many patients. But perhaps more importantly, Dr. Brown's dedication certainly has shone brightly during the PAD, the Lived African American Experience event last February, where he bravely shared his personal story, creating a safe space for PAD patients to discuss the gaps in PAD care that has led to unnecessary amputations, especially among people of color. But his work has just been transformative across so many different platforms and initiatives. And again, through that Save Legs, Change Lives program, he and his team actually conducted more than 5,200 free PAD screenings, educated more than 2,600 community members about early PAD detection, and actually reached an astounding 63 million people through their total education efforts. And his personal connection to PAD, stemming from his father-in-law's battle with the disease, has fueled his passion to address health inequities faced by cardiovascular and vascular patients. His tireless efforts have not only saved limbs, but truly have changed countless lives through his advocacy, his education, and community outreach. And so I really want to give a warm welcome and a big congratulations to Dr. Richard Brown, our Global PAD Advocate of the Year for 2024. Thank you so much for all you do to help save life and limb, Dr. Brown. We appreciate you. The award is well deserved.
Hey, Kim, first of all, thank you for those really, really kind words. This is quite emotional for me. My 17-year-old son, Ricky, is actually watching, and my wife, Lauren, who is also watching, and her father, my father-in-law, Russell, he's watching from heaven. He had quite the battle with peripheral artery disease. It completely changed the trajectory of his life. The last 2 years of his life were terrible. He had both of his legs and one of his arms amputated. I saw the effect that that had on my wife, Lauren. One of my biggest regrets in life is that Ricky never had a chance to meet him, to learn from him. He was an incredibly spiritual human being who accepted me despite the fact that I wanted to steal his daughter from him. So really and truly, he was part of the reason that I did go to Johnson & Johnson. He was a big part of the reason that I wanted to start Save Legs, Change Lives, make it a national platform to reduce the rate of leg amputations in this country and beyond. So that work came from a place of love and passion, and I accept this award with great humility.
Oh, it is so well deserved. I mean, I could just, your passion is just incredibly contagious. And, there are so many people that have, um, life-changing events, and things that happen to their family, and they never seem to do anything about it to help prevent that from happening to others. What is it about your personality that that really got you to turn, this situation into action and advocacy?
It started not when my father-in-law Russell first became ill. He was living on St. Thomas in the U.S. Virgin Islands. That's actually where I met my wife. I remember the first time that I met him. I had just finished up high school, actually, had just started college, and I met his daughter, Lauren, and I was sitting in their living room, and, I was pretty comfortable in his house and had my feet up on the coffee table, and he walked in and he was
I
not
love
happy to see this.
No.
Yeah. And he told me, if he ever came home to his house and saw me with my feet up on the coffee table, he would throw me over the balcony. Their house was sort of elevated. So I must say that our relationship was not off to a great start. But I persevered, and he actually became someone that I would turn to for advice. First, advice about, how to get his daughter to fall in love with me. And then, secondly, I turned to him for a lot of life advice because he was just someone who, as I said, was very spiritual, saw the good in people, had a very positive attitude. So I feel that I picked up some of those attributes from him, which I appreciate. And when things started to change for him and it started to have an impact on me, was when he first became sick. He had long-standing diabetes, and as a result of that, he actually developed kidney failure, required dialysis, and that made him have to move from St. Thomas in the Caribbean, which is where he wanted to retire and enjoy, the back end of his life. He had to move to Atlanta, Georgia, because of his medical illness. We actually thought that he would be in Atlanta for a short period of time and then be able to go back home to St. Thomas. But that was a one-way trip to Atlanta. He never made it back home to St. Thomas. His kidneys were the first thing to fail, and then he developed severe coronary artery disease and required open heart surgery. That was a real medical setback for him, but still he kept that very, very positive attitude. And then the bad news came that he had severe peripheral artery disease, that he had to have one of his legs amputated. I can remember the effect that had on Lauren. She was really devastated by it. I remember the look on her face, and I remembered how sad she was. And when she turned to me and said, my dad is never going to be able to walk properly again, so I'm going to start running in his honor. And Lauren was not a runner. She did not exercise that much at that time. And I wanted to say to her, I didn't say it, like, come on, let's don't be dramatic. There's no way you're going to become a runner.
As the supportive husband you are.
I know, I thought it, but I didn't say it. But she did it. She literally a few months later, we were living in Virginia at the time, and she registered for a race in Washington, D.C. And she actually went up by herself. I was on call that weekend and ran this race by herself in her dad's honor, and then continued to do it. And when I saw her becoming someone who could not run, for 6 minutes, to someone who was running a 5K, then a 10K, then she became a half marathon runner, then she started running marathons. It was very clear to me what had happened to her dad was dramatic. And then ultimately, as Lauren continued to run in honor of her father, his health continued to deteriorate. Um, he had that one leg amputated. Then he had his right arm amputated. And then ultimately, he needed to have his other leg amputated. So one day I went into his room. He was living in Atlanta, and he was this man, on the ground with no legs and one arm. And that image has remained in my brain for decades. He died at 61 years of age. He was a very young man. He died 4 years before my son Ricky was born. And I was then practicing cardiology in Charlotte, North Carolina. But I always said to myself, if I had an opportunity to do something to help prevent this from happening to other people, I was going to take that opportunity. And that stayed with me and stayed with me until COVID happened. And several things happened in 2020. The first thing that happened that I observed was, even though it was one virus affecting us, many more people of color were dying of COVID compared to others. And I started to think about why is that? And I started to understand this concept of health disparities, where the same care is actually not delivered to all people. And it made me start thinking about my father-in-law, and I recognized that the care that he received was very different, probably, to the care that the governor of Atlanta would receive. And I saw that the testing that was done for him, which was very minimal, he sort of ignored. He sort of was ignored, and I felt that this was really and truly an opportunity for me to do something to honor him and again help other people. So that is where my passion came from, Kim.
Wow, what an incredibly powerful story. I mean, we have such an incredible connection to it. And, it's interesting that I would imagine that as many years that have passed, you probably still have those moments like I do, even with my mom that lost her life unnecessarily due to an aortic dissection when she didn't receive the proper care as per standard protocols for that. And I just still kick myself and I wonder what if we could have done this and why didn't I do that? And I can see it in your eyes. You probably have that same experience every single day. Woulda, coulda, shoulda, right?
Yeah, I being a physician, there was an element of guilt in here because, while he was being treated for diabetes and he developed severe heart disease, I was in the medical field. I was a biology major, then I was in medical school, and then I was doing a residency at one of the top internal medicine programs in the country. And I was like, wow, there was this guilt feeling of, well, why didn't you intervene? You had some amount of medical knowledge. He is a family member. Why weren't you more aggressive in the early stages, and maybe you could have helped? And my wife, who's also a physician, I know she felt the same thing. I know she has felt guilt and anger through this journey. So you're correct. Being a doctor and having a family member end up having a bad outcome, you do question, could you have done more for that person?
But it's so interesting because, and I want to talk about how things have and haven't changed since then. And one of the biggest things for me is proper vascular evaluation. More than 60% of patients who are getting amputated for PAD still aren't even having a doctor follow standard protocols by the societies. Even 2024 PAD guidelines for the management of peripheral artery disease, to attempt to try to restore flow prior to any amputation, 90% of which aren't even getting a proper vascular evaluation at all. I just had this literally this week. I've been fighting over the weekend at 1 o'clock in the morning, fighting general surgeons in Southern California who are excited to remove just a toe, but still, a toe is a limb, it's a part of you. Removing a toe without performing a proper vascular evaluation. And we had to push for at least an ultrasound. I really wanted the CTA done, the CT angiogram with the contrast fluid, but we at least ultimately got an ultrasound, but we had to fight for it. They were going to remove this limb without even a proper vascularization. How is this possible? I mean, without even a vascular evaluation, let alone a revascularization. I would imagine it must be frustrating for you to have seen your father-in-law go through this back when and still having the same thing occur today.
Absolutely. So my father-in-law, Russell, he had no evaluation of his extremities. He never had an ultrasound done. He never had a CT scan looking at his legs. He never had an angiogram looking to see if there are blockages that could be opened to save his limb. The decision to amputate his leg was given to him as the only option and the first option. That sticks with me because that still is a major problem in this country. Yeah. There are 400 amputations performed daily. That's a lot of amputations in the United States. And a high percentage of those, as you said, have no vascular evaluation prior to an amputation and no attempt to save the limb, which is very, very mind-boggling to me. And one of the things that I focused on when we were doing this work in terms of saving limbs was how can we detect peripheral artery disease earlier? What's a way to do that? So when I got to Johnson & Johnson, I met a lot of really great people, and several of them expressed an interest in doing something as a big global company to have an effect. And one of the things that we recognize that is a problem is there is a very simple test that can detect the presence of peripheral artery disease. And it's called the ankle brachial index, the ABI. What you do is you measure the blood pressure in the ankle, lower leg, you measure the blood pressure in the brachial artery, and you compare them. So they should be the same number. So in a normal person, let's say that the blood pressure in the arm is 100, the blood pressure in the leg should also be 100. And that would make your ABI be the blood pressure in your ankle 100 over the blood pressure in your arm, your brachial artery, 100 over 100 or 1.0. That's a normal ABI. What we know is as you develop blockages and reduce blood flow to your leg, the blood pressure in your lower leg goes down. So now you can see a situation where someone could have a blood pressure of 80 in their lower leg around their ankle and a blood pressure of 100 in their arm. Their ABI would be the blood pressure in their ankle, 80, over the blood pressure in their arm, 100, or 0.8. We know that an ABI of less than 0.9 is highly correlated with the presence of peripheral artery disease. This is such a simple, non-invasive, safe test, but yet it is actually not paid for by Medicare, Medicaid, and commercial insurance. So one of the things that I thought was very important was let's find people who are at risk and provide them this screening test for free. Johnson & Johnson was quite supportive in this effort. They provided the funding for us to create 2 mobile units that went to different communities and did this ABI testing for free. The other thing that people on this call should know is while all of this was going on, I got to meet Kim. And Kim became one of my favorite people in the whole world because she really, really cared about this. And one of the things was, as a pharmaceutical company, we could not direct where patients would go in terms of their care. And we needed some way to connect these patients to providers. So Kim was like, hey, listen, we have this Leg Saver hotline where we'll give you that number. Patients that are screened that are abnormal, they can call our Leg Saver hotline. We'll get them connected to a physician. So really and truly, that ability to detect it earlier is so important, because if you detect it earlier, patients can change habits like stop smoking. We can control diabetes better. People can get involved in walking programs, which we know improve the flow to the legs. All those things can happen if it's detected early. And so providing this ABI test was a big cornerstone of all the things that we were doing. The other thing that we did was we spent a lot of time in Washington, D.C., connecting with people on Congress, trying to get legislation approved that would allow for Medicare at least to pay for this ABI test so that people could detect PAD earlier. Because quite frankly, the lack of the ability to detect this early leads to the patient showing up late in the emergency room at 2 o'clock with their limb blackened and dying, and them ending up in the operating room the next morning getting an amputation.
And with that work over in Congress, what sort of resistance? It's called the ARC Act. I think it's the Amputation Reduction
and Compassion Act. Yeah.
Act. Where is it stalling? I can't imagine a conversation with any of the senators that would say that this isn't worth putting through if their family member. They even had a fellow, I think, is it going through the representatives, or is it going through, it's going through representatives first?
Yeah.
I can't imagine any of the representatives if they had it personally, but they had even a representative that had it and just recently passed.
Yeah. You know,
And they're still not putting it through.
the first thing I actually learned by these trips to Congress was it's actually not the Congress people running this country. It's their assistants. Like that's the first thing I learned, that you had to convince the assistants that what you're saying makes sense before you could even get to the congressperson. But here is the issue with what's called the ARC Act, Amputation Reduction and Compassion Act. It was introduced by a House of Representative member who actually has subsequently died. And initially, the thought was, you know what? If you're a hospital system or you're a doctor and you are doing these amputations without looking to see if the leg could be fixed and saved, we should not pay you for that amputation. And there was a lot of resistance from hospital systems and doctors saying, you know, legislation should not tell us how to take care of patients, right? They felt that the way it was structured, it was telling doctors in what sequence to take care of patients. And there was a lot of resistance because of that. Well, it was modified. And basically it was modified, and it basically said, what we want is to identify people who are at high risk of developing peripheral artery disease. And we know who those people are. People over the age of 65. If you are of Black ancestry, your risk is higher. If you're Hispanic, your risk is higher. If you have diabetes, your risk is higher. If you have chronic kidney disease, you have a higher risk. People who smoke, their risk of peripheral artery disease is quadrupled. Those with uncontrolled high blood pressure, those with high cholesterol are also at risk. And actually, being obese and or sedentary also increases your risk. So what was being asked was, let's not screen everybody. Let's look at people who are at the highest risk of having peripheral artery disease and perform this very inexpensive, non-invasive test to detect them earlier. Where the resistance came for that was two parts. The first part has to do with a entity called the U.S. Preventative Task Force. This is an entity, an independent entity that makes recommendations to the government about which tests should the government pay for as screening tests. So an example, a mammogram. You're a woman, you turn 40, a mammogram is paid for by commercial insurance in this country. And the reason is it's because the U.S. Preventative Task Force looked at the data and said, if you screened all women in the United States who are 40 years old, your detection rate would lead to an acceptable rate of preventing the ravages of cancer. So it made sense from a cost standpoint. Same thing with colonoscopies at age 45. If you do a colonoscopy on every person at age 45, you will detect enough cancer to make an impact on the cost of health care. The issue with peripheral artery disease is there is no age that you can say, if we do an ABI test on everybody at that age, that it actually becomes cost effective. And that's where the U.S. Preventative Task Force makes their recommendations based on screening of everybody. And then the second issue is the cost, right? That, we have a significant deficit in this country. And whenever something comes up to Congress, they first ask, what is the cost? The issue with both of these things I said was, number one, we're not asking to screen everybody. We're asking to screen the high-risk individuals. And I'm convinced if you screen people at high risk of peripheral artery disease, it does become cost-effective for sure. The second issue is this. If you perform ABI testing on individuals who are at risk and you prevent a hospitalization with a threatened limb, you prevent that patient from needing an amputation, you prevent an ICU stay because someone is so sick because of their advanced peripheral artery disease, the cost savings of those downstream things justifies the cost of doing the ABI test. But quite frankly, the government doesn't look at the overall cost when they make these decisions. They put the cost for testing in one bucket and then the cost of care and complications in a different bucket and don't realize that they're interrelated. So that is the resistance that we have in trying to get the ARC Act across the finish line.
So what can we do to help?
Well, there are several things that you as an individual can do. And this is the first thing that I tell individuals and patients and people. Knowledge is power. When we developed the Save Legs, Change Lives program, I told you one of the important parts of it was going around the country and at no cost to patients, doing the screening tests and detecting it early. That was one part. A second part was actually educating individuals because peripheral artery disease is not well known. If I went to 100 people and I said, do you know what a heart attack is? 99 of them would say, absolutely. The one person, they must be crazy, right? But nearly everybody knows what a heart attack is. If I went to 100 people and I said, do you know what a stroke is? 99 of them would say, absolutely, I know what a stroke is, and I don't want to have one. Only about 40% of Americans are familiar with the term peripheral artery disease. So there is this gap where people actually don't know about the disease and can't advocate for themselves. So one of the things that we did when we developed the Save Legs, Change Lives program was we actually had physicians going into communities and talking to individuals, talking at churches, talking at community centers, talking at shopping centers, right? I gave many of these presentations and told people what peripheral artery disease is so that they would have the knowledge to advocate for themselves and to share that knowledge with family members. The other thing that is really, really important is doctors are very, very busy. If you look at a typical doctor's clinic schedule now, They have 15 minutes per patient. About 5 minutes is spent with the nurse inputting information in the computer. Another 2 minutes is spent with the patient getting comfortable in the room. And before you know it, the doctor on average has about 5 to 7 minutes with that patient. One of the last things that a hurried doctor is going to do is examine someone's feet, right? That's one of the last things that they're going to do. So one of the things that individuals can do is when they are in that doctor's office, take off your shoes, take off your socks, force that doctor to look at your feet and to examine your feet. Because very early on, we notice things that change on the physical examination. The pulse might become diminished. We also notice there might be some discoloration of the foot. Sometimes on the lower shin, there's loss of hair. There's hair loss that can be an indicator of a reduction in blood flow. And there are other things that a doctor can pick up if they just looked at your feet. So I always advocate individuals and patients to force your doctor to look at your feet. The other
And
thing,
it's so interesting that you say that, because one of the reasons why we now have mammograms for over 40 is the Susan G. Komen Foundation and creating diaspora and empowering women to go to their doctors and say, I want this. And it really was this groundswell, I think, that ultimately led to it happening. And so I want each and every patient who is watching to realize you do have power, power in mass. And if each and every one of you who's watching actually went to your doctor, your primary care especially, and said, hey, we got to make this happen. If you went to your representative and you said, hey, we got to make this happen, we can do it. It might not happen overnight, but it would happen.
and absolutely. And one of the things that we do know, and I think that we just have to get this word out, is we have data based on geography. And we know that there are certain parts of the country in regards to amputations where amputation rates are just excessive, right? A big part of it is actually people living in the southeastern parts of the United States. The amputation rate there can be sometimes 10, 11 times higher than other parts of the United States.
Yeah.
Senators living in those states need to know about this, right? So one of the things that we need to do is we need to organize and get that information to the senators in North Carolina, in Georgia, in Florida, in Texas. I mean, I'm concentrating on the Southeast. I mean this for everywhere, though, that really and truly direct communication from constituents to members of Congress can carry a lot of weight.
And also, we need to get the media involved, and you've been played an integral role in that. And one that stands out, I mentioned it in my introduction, is ABC's Severed. And the only one issue I had in talking to the reporter, he was pretty amazing, and I loved his personal story, and it was one of the most well done episodes. But I only had one thing, is that he said that he felt in order to create the change we want to see, we need to just call it diabetes. And I said, well, I think that the issue we have is that it keeps being called diabetes, and people are told that they're getting their limbs amputated because of diabetes. And there are limbs that do get removed because of diabetes itself. You end up with a wound strictly because of the diabetes. It won't heal, but it has nothing to do with the arterial flow, right? And I think that there needs to be a clear delineation between the peripheral artery disease amputation and the general diabetic amputation. In either case, a full vascular evaluation should be performed. But I think when I look at the numbers for our Leg Saver hotline, and we have nearly 1,000 tangible saves where every single one of those was on deck for amputation, more than 30% of those, Dr. Brown, were never even told they had peripheral artery disease before being told they needed an amputation. And every single one of those patients, we suggested getting a vascular evaluation. Lo and behold, they had PAD. And in fact, something could be done to treat the artery and ultimately prevent the amputation. But I'm curious, from your perspective, the impact that this I mean, amazing documentary had, on spreading the word and raising awareness for PAD.
Yeah, so first of all, I really thank ABC News for coming into our home and actually sitting down with me and my wife and us telling the story of her dad and
Yeah.
the work that I was doing. That reached a lot of people. I actually had many individuals reach out to me personally and thank me for that. Individuals who told me, "Oh my gosh, I've been having cramping in my legs for months, and after seeing that special, I actually went and had my legs checked, and I had peripheral artery disease." That is someone who, quite frankly, would have shown up in the emergency room at 2 o'clock in the morning with a dead limb and have it amputated. So I really feel that was really able to get people to be aware of this and maybe advocate for themselves and ask for some testing. I want to point out, though, that what you said is true, that it is not only diabetics that develop peripheral artery disease and lose limbs, right? Diabetes is a major risk factor for this happening, but it's not the only risk factor, and it's not only in diabetics that it occurs. That is very, very, very well known. The other thing that I want to point out from that ABC special that I thought was really, really important was this concept that doctors sometimes have what we call implicit bias or unconscious bias, where a doctor is doing something that they think is going to help the patient, but obviously they're making a decision for that patient themselves that can be harmful to the patient. A perfect example is, we know that there are certain types of blood thinners in the world. There's an old blood thinner that really does not work well, that is very harmful in lots of ways. There are much newer versions of blood thinners that are much safer and more effective. But sometimes a doctor sees a patient and makes the decision without even asking the patient, "Hey, I don't think they can afford the newer medications, so I'm just going to give them the old one," and it's not the best thing for them. The same thing happens in the peripheral artery disease world, where doctors, I think, sometimes make the decision, "Hey, this is a person who would struggle to come in for follow-up testing and treatments. So maybe it might be easier for them if I just amputate the leg and get it over with," right? That is an example of a doctor making an unconscious decision without involving the patient. Sometimes they say things about distance, this person lives so far away, they won't be able to come in and follow up. So let me make it easier for them right now. The other issue that is maybe even bigger is the way that doctors and hospitals are paid for procedures. There's something called a DRG. So for a particular procedure, you get paid X amount of dollars, right? And it doesn't make a difference if it takes you 20 minutes to do the procedure or it takes you 4 hours to do the procedure, the payment is the same. So I think also part of the problem is, quite frankly, the payments for amputations, it's a good number. It's a 20 to 30-minute procedure, and you're done, right? Trying to save someone's limb, going in and putting in catheters and injecting contrast and taking pictures and ballooning and putting in stents and all these things. That's can be a very laborious and lengthy type of procedure. So sometimes people might go, "Wait a minute, do I want to spend 4.5 hours doing this procedure to try to save a limb when I could do an amputation and be paid well?" And I'm not saying that physicians are making decisions based on economics and inconvenience, but I do feel that because of the pay structure, the way that amputations are reimbursed compared to revascularization attempts to save the legs, I feel that there's also a component of that is driving this amputation epidemic.
That is very well said. And I also I tell every one of my patients that these doctors are also the ones that are the limb salvage specialists, the ones that are spending anywhere between 3 and 5 hours to try to save their limb. They're actually risking their life every single time for your limb because of their exposure to the radiation for very long periods of time. And there was a documentary called Scattered that you might want to also take a look at for those who are watching to understand the impact that a lot of radiation has had on a lot of these doctors that are trying to save life and limb. Um, but I really wish, Dr. Brown, that the media would be focusing, and I don't understand why they're not focusing, the ProPublicas, the New York Times, why are they focusing so much on this handful of doctors that might be doing too many of these procedures too early on for the early stage PAD patients for allegedly reimbursement? And some have been actually taken to task for that and fined by the federal government, versus the massive doctors, the majority of doctors that are performing these amputations without even trying. Why is that not the story? The majority of amputations that are being performed without even a doctor trying or even performing a vascular evaluation versus the ones that there might be a handful that might be doing too much, that maybe, and they still haven't found that direct link between doing too many procedures and amputation. I just seriously do not understand why one is more sexy than the other.
Yeah, I want to touch on that because that's important. I want to make sure your audience knows what you're talking about. Several months ago, maybe even a year ago, the New York Times came out with an article about amputation. And the two things that they focused on was one, a couple of doctors who they felt was overusing procedures for these patients. And they were implying that these doctors were doing it for monetary gain, and that's the reason they did it. The second thing that they touched on in this article was the fact that sometimes these procedures are done and then people still end up needing an amputation anyhow, and maybe they could have bypassed the procedure and just gone straight to the amputation. The first thing I'm going to say is that the doctors that were described in those types of articles are a very, 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 very small minority of physicians taking care of patients. And I know this because I work with these types of doctors every day. Okay, that was they shined a light on the outliers. What they also did though was they scared patients, because if I'm a patient and I'm reading this New York Times article, now I'm like, oh, I don't want to go see doctors to check up on my leg because they're probably just in it to make money, right? I really feel that that article was a real disservice to
Yes.
patients, and it discouraged them to seek out medical care that they need. Maybe that was the sexier story. Maybe it was not as sexy for the New York Times to say, hey, listen, guys, peripheral artery disease is underdiagnosed, it's undertreated. There's 400 amputations being performed every year in this country. A majority of those are being done without any type of vascular assessment before the procedure is performed. And
Yeah.
by the way, if you're a person of color, your risk of having an amputation is substantially higher than others, and you need to advocate for yourself. You need to know what your risk factors are and have those modified. That would have been a much better story for the New York Times to have
And they
written.
could have done the same headline. It could have been the same headline. It could have been amputations being performed for monetary gain in the same way that they said that these limb saving procedures would have been done for more monetary gain. I mean, it would have been the same because is there direct evidence for either one? No.
Right.
And I liked your angle better, but it's just I don't understand why it's not sexy. It literally is more prevalent and more deadly than most cancers combined, including what is the combination? Breast cancer, colon cancer, and I think the third one was it prostate cancer?
I'm not sure.
I can't remember. But anyway, I still think that that would have been a better headline as well.
No, and
We
again,
got to get them on board. I'm depending on you as an advocate now. You're global PAD advocate of the year.
no. And again, I really
All in your hands.
the thing that I want to emphasize, again, is because I have seen this firsthand. I have seen the devastation of amputations.
Yeah.
And I don't mean to put my wife Lauren on the spot, but she's on the call. Lauren, why don't you come on camera? Because I do want people to have an appreciation for how devastating this can be to family members. And it's multiple things that we have to do, right? We have to educate individuals, number one, and make individuals aware of peripheral artery disease. They need to know what it is. Even the name is not a great name, right? Peripheral artery disease. It sounds like it's peripheral to your health. It's not central to your health, but people need to be aware of it. The second thing is we need to be able to screen and test high-risk individuals. And that involves some legislation and work and educating Congress people about A, not only is this the right thing to do, B, ultimately it's cost effective. If you can screen and detect disease earlier and prevent the bad outcomes, not just amputations, but all the bad outcomes that are linked to people who undergo amputations, you actually will reduce the overall cost of care for these types of patients by detecting it earlier. The third thing that we have to do is we need more of a presence in media, right? We need to be able to be on the Today Show and the Tonight Show or whatever. We need to be able, our media partners, to allow us, the medium, to get in front of folks and let them be aware of it. If you look at, breast cancer screening, that's a massive campaign, right? Everyone knows what pink means and they understand the importance of this. We need to have some type of social media presence with peripheral artery disease that really has that type of effect. We also need to educate doctors. We need to educate doctors about what this is, how to more aggressively treat it, how to test for it earlier, how to detect it earlier, and how to shift their mindset to being one of trying to save a limb rather than amputate a limb. And then finally, we need discussions with hospital systems because these amputations are being performed in hospital systems. If I'm a hospital administrator, I should want many less amputations and more revascularization procedures being performed in my institution. So there's lots of things, there's lots of heavy lifting to do here, but I think we can make a dent.
I agree. So you have moved on in your career, and I'm curious, along with if you can tell us about your new choices moving forward and how you plan to also continue your plight to save life and save limb.
Yeah, so I was at Johnson & Johnson for many years. They allowed me to work with a team and develop the Save Legs, Change Lives program, where we did a lot of fantastic things. But just like peripheral artery disease is under-recognized and undertreated, there's also another cardiovascular condition that is under-recognized and undertreated. And it's actually patients who have blockages, not actually in their legs, but blockages in their heart. And when you have blockages in your heart that cannot be fixed and cannot be opened, many of those patients are miserable. And then there's a syndrome where people don't have blockages that you can see on a CT scan or an angiogram, but there's reduced flow to the heart in the very, very small blood vessels. It's called microvascular disease. That's another group of patients, mostly women, that are walking around with fatigue and chest pain and shortness of breath and poor quality of life. And then there's a third group of patients who have what we call heart failure. And sometimes with heart failure, it can be that your heart is weak. The ejection fraction, the percentage of blood the heart squeezes, is weak, and you have these symptoms. Or sometimes people have a strong heart, but it doesn't relax well and fills up with blood, and the pressure is high, and these people are miserable. There is a procedure called EECP, counterpulsation, which is a non-invasive test. So many things in medicine we can do non-invasively also, where you put blood pressure-like cuffs on the legs. They inflate based on the cardiac cycle, push blood backwards and down into the coronaries, and increase the blood supply to the heart. They reduce the chances of people with heart failure ending up in the hospital. They increase your ability to exercise and engage in activities of daily living. And these women with microvascular disease, it really makes them feel better and markedly increases their quality of life. So I'm doing work now with a company called Flow Therapy that is the leading provider of EECP in this country, again, because that technology is underutilized. People don't know about it. So part of my goals in life at this stage in my life, now that I'm an old man, is what are things that can help patients that people don't know about that I can bring to the forefront?
That's really interesting. We have quite a few patients, one particularly in Maryland. So I definitely want to get more information on how we can get patients to them. But we have a lot of patients that have this so-called microvascular disease, and we've even had doctors who said, "Oh, I don't think there's any such thing as microvascular disease," whatever. And so it's how prevalent is it? Number one, and number two, how readily available is this technology for patients across the country and even globally?
Good question. So it actually is very prevalent, and that's the problem, right? Doctors, they look at the big blood vessels. So if you look at the blood supply to your heart, to be simplistic, there's the big blood vessels, and then there's the much, much smaller branches. It's the big blood vessels that we can see when we do a CT scan or we do a heart catheterization. Those smaller vessels, those micro vessels, we can't see. And at any time, actually 10% of the blood going to your heart is in the big vessels, and 90% of it is actually in those microvasculars that you can't see. And so when doctors look and they don't see any blockages in the big vessels, they just assume your symptoms can't be cardiac. But in lots of cases, it actually is. And we know that if you can do things like reduce the inflammation and irritation in those smaller vessels, you can raise nitric oxide levels. Nitric oxide actually causes blood vessels to dilate, and the heart likes that. If you can create new blood vessels, taking more blood to the heart, all those things will result in a patient feeling better. And those are the things that EECP does. Currently, the company is based in Dallas. They have an outfit in Charlotte, which is where I work. But quite frankly, we are trying, one of the overarching goals of our work is to make this accessible to everyone who needs it.
Well, we'll definitely be a channel to get the word out. And Marcia, you have a really good question. Go ahead and unmute and ask your question of Dr. Brown.
Good afternoon, Dr. Brown. Thank you for being an advocate.
Absolutely.
I'm curious, if microvascular disease can't be seen on a CT, then how is it diagnosed?
Very, very good question. So there's several ways that you can diagnose this. Number one, MRI. So you can have an MRI study done, and the MRI can look at the flow of blood to all the blood vessels at baseline, and then we give a medicine that is supposed to increase that flow. And if that flow doesn't increase the way it should, you know that there's a problem with the microvasculature. You can also do a test called a PET scan, which involves some radiation, but again, you give this nuclear tracer and you look at the flow, and it can tell you if the flow in those microvascular vessels is normal or abnormal. Another way that you can do it is an invasive procedure with a catheterization, putting a catheter into the main arteries and looking at the flow in the smaller blood vessels. And then sometimes it's just a clinical diagnosis where you've looked at the big vessels, you know that there's no flow limiting lesions in the big vessels, but the patient is behaving like someone who is not getting enough blood. They walk up a half a flight of stairs, they become winded. They stop what they're doing, they feel better. They take nitroglycerin, which is a heart medicine, and it improves their symptoms. So all those things, sometimes you can make a clinical diagnosis, but quite frankly, you have to have it in the front of your mind as a potential diagnosis. And unfortunately, that is not the case. It is not something that many people think about or even recognize is a part of the disease state for many patients.
With so many of our patients go into their cardiologist, and I just had one today because I asked about her heart. She has such severe stenosis in her blockages in her aorta and her iliacs. And I was thinking, you know what? I bet you have some significant blockages in your heart too, or at least severe narrowing. And she said, no, my doctor took the stethoscope and he said, did an ECG and said, I'm fine. And I said, well, that doesn't mean you're fine. We've even had, unfortunately, someone who had a nuclear stress test, got the results, said he was okay. And the poor thing, one of our patients, he passed in the parking lot, leaving the consult of a massive heart attack. And so, how do you get your doctor to do these advanced tests, such as the PET scan? We were also told by Dr. Parag Doshi, who is a pioneer in CTO crossing, or chronic total occlusion crossing of the coronary arteries. He's written a lot of publications on it, developed the techniques for it. And he told many of our patients at our most recent seminar in Chicago that fatigue is now the new angina, and that anyone who has this increased fatigue should actually ask the doctor for a PET scan, a PET scan.
Yeah, so that's one thing I want to make sure people understand, and should tell their friends and their loved ones. The classic symptom for heart disease is what we call angina: chest pain, chest tightness, chest squeezing. But a vast majority, a high percentage, I should say, of patients who have heart disease, they don't have chest pain and they don't have angina. They have what we call anginal equivalents. I feel short of breath when I walk. I feel fatigued. Things I could do 2 years ago, I can't do now. I don't have the energy to go to the mailbox and come back into the house, right? All of those could be signs of reduced blood flow to the heart. And sometimes as doctors, we get caught up is if they don't say chest pain or they don't say chest tightness or they don't say angina, it's not the heart. But that's not true. Lots of times you don't have actual angina. You have what we call anginal equivalents. That is the sign that your heart is compromised.
This is incredible because here you are, you're a global PAD advocate of the year. Next year, we're going to say you're the global heart advocate of the year. Always paving new paths. It's amazing. It just speaks such volume for your character. We do have a few other folks really quickly that want to chime in here, offer some comments, ask a couple of questions, and then I'll have one final question for you if you still have some time.
Sure.
I'd like to open it up, thank you, to Douglas. Douglas, go ahead and unmute and ask Dr. Brown, Global PAD Advocate of the Year, your question.
Congratulations, you deserve it. Great talk. I'm curious, going back to the college and the doctors in the very beginning with primary doctors, how much education do they really get in school on PAD and what we talk about today?
Yeah, that's a very good question. So I've actually thought about this. I've said, wait a minute, how much peripheral artery disease education did I receive? And I would say it was very, very minimal. And I've actually looked into this, that even medical students in 2024, how much education are they receiving on peripheral artery disease? It still is minimal. Most of the education that medical students are getting is about things like stroke and heart attack and congestive heart failure, etc. peripheral artery disease is still something that many, many medical students and doctors in training are not being taught enough about.
Yep. Thank you. I want to open it up if anyone else has any other questions or comments. I see someone, I don't know the name, but go ahead. I will just call you iPhone. Go ahead and raise and ask Dr. Brown your question. Or we will go with Marcia. Marcia, go ahead and unmute.
Yes, thank you, Kim. Congratulations, Dr. Brown. I remember your story from, it might have been the thing that Charles and Kim were heading up. Very interesting, and I'm sorry about your father-in-law. My question is, you were saying about, go in and take your shoes off, that doctors are rushed now. And that is really, really sad. But a general practitioner, when a patient comes in, does he have a checklist that, like, I have to get my stethoscope out, I have to listen to their heart, I have to take their pulse, or the nurse does? Like, how can that just fall under the cracks? And I, by the way, I was fortunate. My GP, my former GP, is the one who diagnosed me. She knew exactly what it was. I told her my feet or my leg hurt when I walked, and then when I stopped, it didn't. So I was very lucky, but I just don't understand doctors not looking at the feet.
Yeah, so you make a good point. What part of the reason doctors don't look at the feet is they're busy. But the other thing that I didn't mention is protocols. So quite frankly, it would be very helpful if at hospitals there were protocols about how to manage these patients. What is going on right now is it's dealer's choice, right? If a patient comes in, the doctor can decide, yep, that person goes for amputation, that patient goes to try to have their limb saved. It would be great if there were protocols that sort of said, no, if a patient shows up with this, you should do this testing, A, B, or C, whatever. Where now you can take out that subjective feeling for the doctors, and it's written down what the workup should be. Because currently that's not what we have in place, but quite frankly, that's the type of work I'm going to continue doing as I interface with health systems, et cetera. Let's come up with a written protocol that sort of ensures everyone gets the correct type of care, the correct type of testing before an amputation is recommended.
Oh, may I just follow up, Kim?
Yes.
Well, what I really meant was, if you go for your well visit, just your annual well visit, they're going to do a few things, maybe push on your stomach, listen to your heart. Do they have a checklist for that?
No.
And so they wouldn't even have to get their stethoscope out, technically.
No, there's no checklist about which parts of your body a doctor has to examine when he or she sees you.
That's pretty sad. I mean, because it would be as easy as just like you get the pulse oximeter on your finger, why not have one for each of your toes? I mean, just as they're doing the blood pressure in the arms, while they're doing that, you always have the pulse oximeter on your finger. They check your temperature, and they can check your toes. I mean, very easy. And our acronym, the one thing we tell every single patient is, hey, doctor, let's chat. CHAT. Carotids, heart, abdomen for aneurysm, and T for toes. Check my pulses. So we say, hey, doctor, let's chat. And you, as the patient, direct the appointment. One more we wanted to get in. Charles. Charles, go ahead.
Congratulations, Dr. Brown. Always nice to talk to you and see you. You're very inspirational to me. The passion in which you do what you do is very inspirational. My question is, now that DEI has become like a bad word in society, that it's become very political, that how do we go about still doing the work, but rebranding it so that it can be more acceptable?
Yeah, so good question, because again, we didn't really touch on this, but if you look at the leg amputation rate, in blacks, it's 4 times higher than non-blacks, right? So that's a huge disparity based on race, all right? But again, I don't want the message to be lost. There are many non-black legs being amputated inappropriately in this country also. So my feeling is, let us make a push to reduce leg amputations in everyone, regardless of whether they have diabetes or not, whether or not they're black, white, Hispanic, or Chinese. Let that be our focus. And the people who are disproportionately affected the most, they'll benefit even more. So instead of making this sort of, about racial disparities per se, let us make this about appropriate medical care. What can we be doing as physicians, as clinicians, as society to really and truly reduce what I call a PAD-related amputation epidemic?
Yeah.
Thanks a lot for the question. Hey guys, I want you guys to meet someone. Come over here.
Yes.
My son Ricky. Hey Ricky, say hi.
Hey, Ricky.
Hello.
It's so good to meet you. How do you feel about your dad, and seeing what your dad is doing to save life and limb? How does that inspire you and your plight in life?
I don't know. Yeah, he is definitely a big inspiration for me. Someone who pushes me to be the best I can every day, and seeing all he does, like it's amazing how he can be such an amazing father to me every day, and also go above and beyond for others. So it's just completely amazing what he can do.
Does that inspire you in terms of your choice potentially in the future for a career?
Yeah, it definitely does inspire me, I guess, to go like down the road he did with like I've always been interested in like the sciences and do something in that and do something where I can help change lives of people.
I love that. Well, we'll have you as a doctor. We appreciate you guys so much. Thank you so much. Great to meet you, Ricky. Thank you so much, Dr. Brown. I only have one more question for you. It's a question we ask everyone about, and I have a feeling where it's going, but it doesn't matter whether you'd said it before, if you have something new that this triggers. But when I was at Forbes magazine, we had a series for executives to learn just something deeper about them. And we called it the 10 minutes that mattered. That moment, that defining moment in your career or your life, that truly has led you in the direction that you're going. For us, we call it the 6 minutes that mattered because it's a sponsored series and it has to do with a particular device and the time that you need to maintain a balloon inflated. So, what are the 6 minutes that truly has mattered for you? That defining moment in your life, a conversation you had, a clip in a movie, an eye-opening experience. What are the 6 minutes that mattered?
Yeah, so this has nothing to do with peripheral artery disease. I had a partner when I was much younger. I had finished my cardiology training, and now I was a cardiologist practicing. I had been in practice for about 3 years, and I had a partner who was about 15 years older than me. So he had been practicing for almost 20 years. And we were in the hospital together. We were working in a very big, busy hospital. And he came up to me once and he asked a question about a patient that he was taking care of. And I do remember the moment because when he asked the question, I do remember saying to myself, man, that was a really basic question. Like, shouldn't he already know that? So I answered the question and he walked down the hallway, turned the corner, and then he came back to me. And he said, hey, listen, I know that was a really stupid and simple question, but really and truly, I don't want to make a mistake with this patient. And he walked off. And that night, his name was Tom Kelly. I called him up. I said, hey, Tom, like, did I say something to offend you? And he said, hey, yeah, you actually offended me because, I came to you with a question, and I was looking for your advice, and just your body language, your facial expression, you kind of made me feel dumb, and that's a moment that has like always resonated with me in regards to people and how I interface with people and patients, right? People remember how you make them feel. And when you are doing good work with folks and trying to get things done, you want people to feel included and part of the process. When you're in front of patients, you want them to feel listened to. So I would say that moment is sort of really defined my career. Tom Kelly actually eventually died of brain cancer. And in his final days, when I was visiting with him, I told him how much that changed my life. So that's my 6 minutes.
Wow, that was so powerful. Dr. Rich Brown, thank you for all you do. Thank you for your inspiration. Thank you for your contagious passion and your energy. Our Global PAD Advocate of the Year for 2024, Dr. Richard Brown, thank you.